Thank you, Saad. Thank you for the invitation. Congratulations for the conference. It's very nice. Everybody's done excellent presentations. It's hard for me to close up this section because everybody was pretty good, actually very amazing. My topic is kind of low tech compared to all the tests and surgeries. We're talking about, benign anorectal disorders, which at the end of the day is what most of our practice is, as, friendly neighbor colorectal surgeons. And, there are pathologies that can really, that we can really help patients with because they're very uncomfortable. So in terms of conflict of interest, I'm a proctor for the THD company. Starting off with just a few elements of anorectal anatomy and physiology. We know that, but generally speaking, the rectum is where the feces are stored and help us with continence and decided when to go to the bathroom. The anal canal in the last part of the digestive tract, leading to the anus. The internal and external anal sphincters are the muscle that promote the continence. The internal is involuntary, the external is voluntary, and they are completely intertwined with the pelvic floor, like we discussed with Irma. The dentate line is the landmark dividing the upper and the lower anal canal with different nerve and blood supply, which is very important, for cancer surgery as well. And then, most importantly, the internal hemorrhoids and the external hemorrhoids. The internal hemorrhoids are just vascular, they're like specialized vascular cushions, sinusoids. They get engorged when, to promoting continence in specific settings. And then external hemorrhoids that, generally speaking, are just perianal skin. That can be more or less loose, creating tags, but overall is not per se a pathologic thing. In terms of physiology, we just discussed briefly, the whole anorectal complex assists with the continence maintenance, with defecation control, talking about pelvic floor, the anorectal angle regulation by the pubis rectalis needs to be coordinated in terms of relaxation and contraction to promote and to allow the defecation. Definitely sensory discrimination, very important for defecation control, incontinence, so on. And then obviously mucosal protection and lubrication. So talking about history, the anorectal disorder is so low tech that Egyptians talked about it in the 1700s before Christ. I don't know if I was like Indiana Jones looking for this papyrus and translated. I don't know exactly what would have found, but they did talk about it. It was something that's been a big problem for a long time. Classical Greece and Rome, they had treatise about this problem. Talking about Hippocrates in Greece, Galen in Rome. These are pictures of actually anorectal instruments that were found in England, old England in the Roman time. There were like knives, there were probes, there were enemas. Well, there was a big thing in the medieval as well. And then, in the medieval society, we actually have, as a proctologist, we have a saint protector, a Saint Fiacre, who was from Ireland. He was an herbalist and used to treat these things, and venereal disease, just throwing it out there. So, hemorrhoids. This is what we deal on a constant basis, especially Lydia, our nurse practitioner. It's very common disease. Some statistic, like 50% of the population will have this problem over age of 50. The main risk factor to develop issues with internal hemorrhoids, which is the main focus, is increased pressure of the rectal veins. And this happens mostly with abnormal bowel movements, diarrhea, pregnancy is a big one, hereditary, difficult bowel movements, and so on. Symptoms might appear mild, but they really impair quality of life, intermittent bleeding, pain, irritation, sensation of tissue prolapse, definitely impair quality of life, a lot of embarrassment for the patient. And sometimes they just don't go to the doctor to discuss this just because they're embarrassed until things are harder to take care of. In terms of internal hemorrhoidal disease, the most common classification is the hemorrhoidic grading system that we all know. Grade 1 is when the hemorrhoids bleed. Grade 2 is when they protrude, but they reduce spontaneously. Grade 3 is when they protrude protrude and the patient has to manually reduce. And then we have the grade 4, then we prolapse and the patient cannot reduce, and most of the time needs like urgent surgery. So in terms of management, changes in diet and lifestyle, this is really paramount, and we all know that. No matter what type of procedure you do for the surgery, if the patient does not fix that type of issue, the results, they're not going to be great. Along with topical ointments, they can, again, improve the symptoms. They don't necessarily long term. So the three main steps that we use, the two main steps are office-based procedure and surgery. So the office-based procedure, mainly rubber band ligation, and less common is sclerotherapy, which I'm going to touch a little bit later. In terms of hemorrhoidal surgery, the main three pillars of our approach are excisional hemorrhoidectomy, which is historically the most common and with the best long-term results procedure, and then transanal hemorrhoidal dearterialization and procedure for prolapsing hemorrhoids. They are less invasive and address specifically the internal hemorrhoidal issues. This is just a couple of pictures about the office-based procedure. With the anoscope, we identify the base of the internal hemorrhoidal pile. We have this instrument, which is a little barrel with the rubber band. We grab the rubber band with the little clamp, and we release it at the base of the rubber band. The rubber band is supposed to stay for a few days. It strangulates the tissue until it sloughs off. And the main function of this procedure is to kind of elevate the protrusion of the tissue and kind of restore a little bit of anatomy. And this has been shown to improve the symptoms and to actually improve the emptying of the veins and the normal pattern. In terms of sclerotherapy, there is something that we do in the office as well, is injection of a sclerosing agent. So we use phenol. This is the advantage of this procedure is that it can be done on patient on anticoagulation. The results are pretty much comparable to the rubber band. This is the excisional hemorrhoidectomy. This is the procedure that's been described for the longest in the surgical world. The excisional hemorrhoidectomy consists in removing the whole pile from the base of the internal hemorrhoids to the perianal skin. As everybody knows, we have 3 piles, 2 on the right and 1 on the left. And so the procedure can involve the excision of 1 to 3 piles at the same time. Obviously, it's done in the OR with local anesthesia and sedation for the most part. We have a technique where the wound is left open, is the Milligan-Morgan, and we have the most common technique that's used is the Ferguson technique, where the actual incision is closed. This procedure can be done with the electrocautery, can be done with a harmonic device, done with a laser, but they're more or less the same results. This is the THD procedure that over the past several years has been considered a very reliable option for the patient, and we always discussed. So this is a procedure that only addresses the internal hemorrhoids, that not involve the excision of tissue, but is done with sutures applied through an anoscope intraoperatively with an ultrasound on the tip. The ultrasound finds the branch of the internal hemorrhoidal artery that is closer to the hemorrhoidal pile, suture it, and then with the rest of the suture, you PEX-him and you ligate and elevate the tissue so that it's elevated in the upper anal canal and kind of restore the anatomy of the area. There has been different iteration of the technique, but this is how it's done. And so this is just a little table to kind of do an overall of these procedures. So the rubber band is the best procedure that we offer for low-grade hemorrhoidal disease. It's an office procedure. There's minimal downtime, very low risk of complication other than bleeding. and discomfort for a day or two. There's a very rare complication of sepsis that we mentioned, but it's really rare. And obviously there's a good patient satisfaction because we don't go through the process of surgery. In terms of surgery, at least in my practice, I usually discuss either hemorrhoidectomy and THD. The PPH is done with a stapler. It's kind of fall out of favor. I was just told that actually the company is not producing the stapler anymore. But in good hands is a very good option as well. So the excisional hemorrhoidectomy is the one that has the best track record in the long term. It's considered most effective, but it's also the most painful, especially when you do a radical hemorrhoidectomy with 3 incisions, cutting all the piles. And there are definitely potential risks, not only for prolonged recovery, but there's a risk of creating too much scar tissue in the perianal skin when you remove too much skin, and there's a risk of injuring the sphincter muscle because you do expose it during the procedure. But again, obviously we still do it. Is a very good procedure, especially for very minimal disease with a big skin tag, so a lot of external hemorrhoid. If that's a problem for the patient, the THD does not address that, or a PPH, so you do that. And then the transitional hemorrhoid dearterialization, again, for kind of higher grade disease, grade 2 or 3, tends to have a quicker recovery than excisional hemorrhoidectomy, less complication. In the long term, the recurrence is a little higher, but the patient tends to be happier. The recovery is faster, so that's the trade-off. Anal fissure is something else that we see commonly in the office. Rectal pain and bleeding is the karma of many of the office days. But the problems start with the microtrauma to the anal canal. Most of the time it's irregular bowel movements, usually hard, dry stool, but can also be caused by diarrhea or frequent loose stool. That microtrauma initiates a cycle of pain and spasm. So you have the tear when you have the bowel movement. You have pain mostly for the subsequent 3 to 4 hours. Because of the pain and the inflammation, you start to develop spasm of the internal anal sphincter, and so you develop like a high basal anal pressure. This increased pressure decreases the perfusion of the area where the fissure is, which typically is like midline anterior, midline posterior, and local ischemia cause a delayed healing. And so that's what causes the chronicity of this problem. Like I was mentioning, the location, so the main classification in our practice, the anal fissure is typical and atypical. So typical is when it occurs and we examine in the posterior, midline posterior and midline anterior. When we see a fissure that is not in those 2 locations, then we start thinking kind of outside the box. So this is Crohn's, this is an infection, this is like a HIV proctitis, this is TB, this is leukemia. It can be an anal cancer and so on. This is how like a chronic anal fissure looks. So the acute fissure is just a tear, and you can very easily see in the offices the patient is comfortable enough to allow spreading of the buttocks. In the chronic fissure, you actually visualize the fibers of the internal sphincter muscle. There's an external skin tag, and if you end up being able to do an anoscope or doing the surgery, most of the time you see a big sentinel pile inside. In terms of management, the conservative management is the first line for acute fissure. Again, changing lifestyle, management of constipation, fluid intake, sit spats. But when it becomes persistent or chronic, then you add something. And our first line of adding is a compound ointment with the calcium channel blocker, along with the local anesthetic. We usually order nifedipine and lidocaine from a local compound pharmacy. Especially like in early cases, that's really effective. It's kind of like labor intensive for the patient because it needs to be applied like several times a day, and that's not really convenient for many patients, but it does help. It actually has a pretty high effectiveness, even though increased recurrence. The next step is essentially surgery, and again, the mainstay of the procedure is to relax the internal sphincter spasm. So surgical, you can do it by either injecting Botox to the internal sphincter muscle. Many times when we have chronic fissures, in that case, we also, debride the scar tissue related to the fissure. And then the most traditional lateral internal, sphincterotomy, which is more invasive, but in the long term is a better results. But obviously with the caveat that once you divide the sphincter permanently, then you put the patient at risk of like bowel control issue down the road, and as we see mostly in female patients. In a subtype of anal fissure, when there's just like almost like a chronic sore and the patient doesn't have a lot of spasm, then we do anocutaneous flap. This is just a little graph showing the healing rate versus recurrence rate. We see that the conservative management has a good healing rate, but is definitely improved with either Botox and the lateral internal sphincterotomy. And then another very important issue that we see very often is rectal abscess and possible subsequent anal fistula. So I'm going to talk about the cryptoglandular type of abscess, which is the most common. So we talk about Crohn's disease, and other disease can cause this type of problem. But for this topic, we talk about the most common one. That is the cryptoglandular infection. So the anal crypts have little glands in there. For mostly bad luck, these crypts get clogged. There's an infection starting there, and the infection spread to the surrounding tissue, most of the time going through the sphincter muscle. It's a very common thing we see in really like on a weekly basis, almost on a daily basis in our office. The mean age of presentation is 40 years. Most of the cases occurring between 20 and 60. The adult males are about twice as likely to develop anorectal abscess and fistula compared to females. And another historical reference is that Sankin had an anal fistula. And I just want to mention this because, the surgeon who did the procedure and was successful probably contribute to developing of surgery a lot, because before that, in the late 1600s, surgeons were, almost like workers, essentially. They were not given the, the prestige and the acknowledgement that physicians, internal medicine physicians were given. But, because the physician was able to treat the Sun King from this problem, the king was happy. And so give fundings, allow them to be part of the, the Academy of Physicians. And, if the king, would have died after the procedure, would have been a lot different for surgery. All right, so few landmarks about, the rectal abscess, which is the first stage of, the perirectal infection. So it's very important to define where the abscess is formed. So the most commons are around the perianal area and the ischiorectal fossa, and less commonly in the intersphincteric space. And there are supralevator abscesses as well, but they tend to be not necessarily from the cryptoglandular etiology. This is just a little picture that shows, how the process works, the natural history. You have the infection of the gland, progression of the infection in the ischiorectal space here. The abscess drains. Sometimes it needs to be done surgically, sometimes opens up by itself. And then once the abscess is drained, the sepsis resolves, scar tissue forms, and in about 50% of the cases, there's a permanent fistula tract that remains, which is essentially a tunnel that connects the internal opening in the anal canal to the external opening, perianal skin, or wherever that happens. The most common type of fistula that we see in the practice are the intersphincteric, meaning that only the internal sphincter muscle is involved in the tract, and the transsphincteric, where both the internal and external muscle are involved. And that's obviously something very important to know to decide what appropriate treatment. Less commonly, we have suprasphincteric abscesses, we have extrasphincteric abscesses, but those are, for the most part, not associated to cryptoglandular origin. they can be, but something happened in between. There's either like a difficult operation or like a Crohn's disease, etc. Good soil rule is what kind of allow us to have an idea of where the internal opening is in relation to the external opening. If the external opening tends to be anteriorly, it tends to go through like a radial straight line towards the internal opening, proven that it's within 3 centimeters from the anal verge, because if it's above 3 centimeters, this becomes more unpredictable. While in the posterior area of the anus, an external opening tends to drain in the midline posterior. Talking about surgery, definitely the decision for surgery needs to consider the location of the fistula, the amount of muscle involved, gender of the patient, and other issues. But generally speaking, the easiest way to treat the fistula is a fistulotomy. So you place a probe, like the one we see from the Roman time, across the tract, and you divide the tissue right above that probe, which would involve definitely anoderm and some sphincter muscle. You debride the chronic inflammatory tissue. Sometimes you can marsupialize. We don't do it commonly, but there's not always an option. Placement of draining seton is something that we often do, especially in patients with complicated disease, history of Crohn's disease, for example. You don't want to perform a fistulotomy in those patients, or when you think that you're going to cut too much muscle and there's a potential of affecting bowel control issue, we put a temporary seton drain. And that seton staged the field for a secondary procedure later on, possibly, where you can repair the fistula without cutting the muscle. And the two most common procedures that we do for these, to this extent are the ligation of intersphincteric fistula tract, which means finding the plane between the internal sphincter muscle and the external sphincter muscle. After 2 months of seton, the scar tissue around the fistula is nice and formed. You can find this place, suture and divide, sort of like obliterating the fistula anatomy. We usually place a little piece of biologic mesh as well to reinforce the procedure, and it works very well. There is, it's not 100% as the fistula, but you don't, incur in the risk of damaging the sphincter. And then the rectal mucosal advancement flap, when the internal opening tends to be a little bit higher and there's a lot of muscle involved, you can do this procedure by mobilizing some rectal mucosa right above the internal opening, closing the opening, debride the tract, and then buttress the internal opening. And there's another good option that we have. And so just to recap quickly, so the fistulotomy is the procedure that has the highest success rate. There is definitely a risk of incontinence, depending on many factors like the amount of muscle, the location of the fistula, patient of the gender of the patient. The recurrence rate is low. There are some risk in terms of like wound healing, but not much. They have a longer recovery because the wound is open, but again, is the most effective. In terms of the advancement flap and lift, those are good procedure. They have still moderate to high success rates. There's no risk of injuring the sphincter, and so there's very low risk of incontinence. In terms of complication, like every anorectal surgery, there is bleeding, infection, failure of the flap, for example. But those are all things that we think in advance, and again, the advantage is not to injure the sphincter. In terms of other techniques, there's been talk in the past about fibrin plug, fibrin glue, some video-assisted anal fistula surgery, but those really not very well studied. They have good short-term results, but they're not very good term results, so we don't do it, and we don't offer that for the most part. And that's it. Thank you for your attention.